So evidence-based practice has been a massive and positive, overly positive movement within the physiotherapy profession. If we were to look at from a philosophical perspective, Thomas Kuhn would describe a paradigm shift when lots of people start talking about the philosophical assumptions of it. So certainly over the last 10-15 years, evidence-based practice has come under some scrutiny, mainly because we have tried to understand what we believe is evidence and what sources of evidence are. So if we were to look at a perspective of evidence coming from the scientific research, one of the challenges is that there's been an assumption that randomized control trials or systematic reviews of randomized control trials have a higher power than other forms of evidence, including clinical judgment. The problem is that when we utilise that judgment in clinical practice with the individual case, the paradox is that we exercise that judgment in order to implement any of the evidence from the randomized control trial. So we need to rethink evidence and what the notions of evidence are. So if we consider Sackett's work, looking at the best of patient values, clinical experience and the research, there has to be some form of mechanism by which we can operate that in individualised cases. One of the challenges is that population studies, including randomised control trials, may not be representative of the individual case. We deal with individual cases, we don't deal with population sizes. So there is a risk of an ecological fallacy, which means that if we have a large randomised control trial, the average treatment effect, for example, may not be the case if I apply that treatment to an individual. That is not to suggest that randomised control trials are bad, not at all. I think they're essential. But when it comes to causation, I'm not sure that randomised control trials are proof of cause. That depends on what we believe in the notion of causality. And if we believe David Hume's perspective, which is where the norms of science suggest causation is, which is frequently observed events which happen with regularity, that are proposed with counterfactual dependence and associated with I forgot what it's called. I'm going to have to rewind it. Temporal priority, yes. Temporal priority and constant conjunction. So A plus B equals C, and it will always be A plus B equals C. If B is not present, C won't manifest. These are the norms of science, but there are cases where that cannot be the case, particularly in open systems. Open systems meaning that lots of causal powers can interact in non-linear ways. So randomized control trials are fantastic at telling us the difference making between the interventions, but they don't necessarily tell us what is causing. They can point towards cause, but they don't give us causation, in my belief. So we therefore have to think about the nature of causality when we think about the individual clinical decision making. We can look at epidemiological evidence, we can look at randomized control trials, we need to think about dose, response, and also a mechanism, and we need to think about representative cases in order to be more confident about what we're doing in terms of causation. So there is a number of challenges that we need to think of, and I think we need to think of it beyond Sackett, who I think had fantastic work that he's done, and he's put us in a very strong position with regards to moving physiotherapy and medicine forwards. But if you look at Trish Greenhall's work and a number of others, they've been quite rightly critical in a fair way about evidence-based practice. And I think we as a profession in physiotherapy need to move alongside that way. So the issue of causality, I think if we look at a dispositional view of causation, I think it can offer a number of different solutions to these types of problems. I think for those who aren't aware of dispositionalism, it basically is a philosophical view of causation where causal powers tend towards an effect, or tend towards or against a manifestation of an effect. Those causal powers can interact in non-linear ways, and it's very context sensitive. So an example that Stephen Mumford gave was that if you add hydrogen to a fire, it increases the fire. If you add oxygen to the fire, it increases the fire. But if you add hydrogen to oxygen, it takes the fire away. So, if we think of causality not just as additive or subtractive, but we think about how interaction is important, hence an importance on mechanisms, I think we can develop our clinical reasoning and thinking in a much more person-centred way. Because what we're looking at is we're not trying to divide a person into various component parts, and we're not trying to categorically put them into biological or psychological or social factors. What we're trying to do is we're trying to understand all of the relevant causal relationships within that individual case, and we try to guide a person towards recovery. So I think looking at it from a dispositional perspective has certain advantages, and I think it has certainly changed the way I think about clinical practice, and I think that I have had better outcomes as a result of it. I guess the interpretation of this of a dispositional approach is that some people may misinterpret it as an anything goes type of relativism. And it's very important to recognise that this is a realist approach. It is not something that is, the patient prefers this, so I'm going to do this. It's a pluralistic approach. By that I mean it does take the best of the science, but it also you consider the philosophical biases of that science as well, of the sciences. But it very much places, I believe, dispositional, a philosophical approach, balances the science with the humanities. And we deal with humans, and they're complex, and we live in complex socio-economic and political circumstances. So this realist view of powers, I think, really can move the agenda forwards. What are the limitations? I think the limitations are we have to feel comfortable with uncertainty, and there's a vulnerability associated with that. I think people need, or rather, be very cautious about saying need, but I think the physiotherapy profession as a whole would benefit from looking at causation in a different way than perhaps they used to, and this is quite a challenge. And be freely available to discuss the natures of causality and philosophy, where historically we perhaps would have avoided such conversations. Perhaps we didn't think that it was as relevant, or certainly it could be seen that this was not needed, and that science itself can answer all the questions. I think that may be true if you consider sciences in a very much biomedical perspective, where you look at single causes making single effects. So a biomedical approach, which is associated with a curative thesis, implies that if you have an agent that is causing a disease, you treat the disease by eliminating that cause. So, for example, smallpox. So you cure, curative thesis. But the problem is that we live in a world of very difficult lifestyle factors, challenging lifestyle diseases, and we have an increased age and multimorbidity. And I think a biomedical approach, we have been talking about for many, many years, needs to give way to an alternative. That's not to suggest that the alternative, such as the biopsychosocial model, has not been helpful. It's how it's been implemented. And as I mentioned before, I think if we separate individual persons into discrete biological, psychological and social parts, if you, for example, exclude plausible biological mechanisms, then what's left is psychological and social manifestations, and that person could be left being labelled, stigmatised, and having even poorer health outcomes as a result. So perhaps we need to look beyond the biopsychosocial approach and be open to the idea that there are potentially other models available. And I personally think at the moment the biopsychosocial model is probably the best model that there is that's in place. But I think that we possibly need to think about its limitations and think of potential new opportunities that work beyond the biopsychosocial approach.
Okay, thank you, Matt.
Thank you.
Thank you.